Thank you for inviting me. And I will address a completely different spectrum of patients than we heard from Dr. Youssef recently. I will focus on a small group of patients, but at very high risk, and I'll review why we are where we are in the treatment of these patients with systolic heart failure. I'll start my review in 1929 and the textbook from Paul Dudley White, when for the treatment of heart failure there was digitalis and rest, that's all. And over the next 45 years, not much happened. So this is from another textbook in 1974, which happened to be the year when I came into cardiology and after some years in internal medicine. And then important agents as diuretics had become available, which was of importance for the symptomatic treatment of these patients. If we look into the present version of the ESC guidelines, we can see now that we have a whole cascade of combinations of both drugs and devices. And so there should be an orderly introduction of these options. And so a lot has happened over these 40 years or so. And I'll focus on the first upper part here, the ACE inhibitors and the MRI antagonist. This concept is based on a neurohormonal activation that is happening in the compromised circulation. And you're all aware of this, but that was actually something that grew, an understanding that grew in the 60s and 70s. But at the same time, there was a concept of vasodilating and unloading the sick heart. And but we became interested in the neurohormonal activation, both in the sympathetic nervous system and the renin-angiotensin-aldosterone system, which then created a vicious circle with vasoconstriction and sodium retention, and things got worse. So we worked in the 70s antagonizing the sympathetic nervous system with beta blockers. And but then grew the understanding of the RAAS system, where angiotensin 1 is converted to angiotensin 2 by the enzyme angiotensin-converting enzyme, mainly located in the pulmonary circulation, and you will know about this. Now, this system is a cascade of various peptides, and so the system can be blocked on various levels, from the renin itself down to the conversion of angiotensin 2, blocking of AT1 receptors, and then also on the aldosterone hormone. I came into awareness of these agents in the early 80s when I spent a year in San Francisco and was introduced to a hemodynamic study where we evaluated MK41, later called enalapril, and could show that it had vasodilating properties, which was at that time the important mechanism for unloading heart, a concept created in the 70s by Ross and others. So we could show the vasodilating effect of this. But putting into the context of what I said, the neurohormonal activation, and we had the work with beta blockers already ongoing, we managed to convince Merck to sponsor a trial where we should look into outcome of this agent, enalapril, and together with Dr. Cheksrud from Norway, from Oslo, we managed to initiate this, what was named the consensus trial, where we actually, in a fairly small group of patients, 253 patients, and then the study was stopped by the safety committee because of these effects, a very clear effect on mortality. There were only 118 deaths, and the reason is, of course, that there was already in 6 months, there was a 50% mortality. It's a very high mortality and a good effect of the drug. But this small trial convinced the medical community to an extent that there has been no more placebo-controlled trials with an ACE inhibitor in NYHA class 4 patients, because those were the patients we recruited to the trial. So this small trial really made an impact, but it wasn't really enough, because this was the, so to say, the end of life. What we could show also, what in all these very symptomatic patients, there was a hormonal difference in blood levels of noradrenaline, angiotensin II, and aldosterone, and the outcome was very much related to the hormonal level blood concentration we found in these patients. So, but this there was a need for more data and important data, and the SOLVE trial with 10 times as many patients and led by Dr. Youssef and published 4 years later than the consensus trial really made it, these trials and this concept of treatment into all patients with, all symptomatic patients with heart failure. So the SOLVE was obviously a very important trial as well. So when we did the 10-year follow-up of the consensus trial and patients, that trial was a very short duration, we could see that almost all patients had died already within 5 years. So there were 5 surviving patients with 10 years, all in the original enalapril group, but there was obviously a large unmet need. We needed to do better. So what we could do was try to block this system better, more effective. If you block the angiotensin converting enzyme, you can still get angiotensin II production through an kinase enzymes, and also if you blocked, you increase levels of bradykinin, which was of potential importance for side effects. So maybe it's better to block further downstreams in this cascade and using instead a targeted receptor blocker, and maybe we could do it even better so if we combined an ACE inhibitor with an angiotensin receptor blocker. And we designed, together with Dr. Youssef, a CHARM program where we actually had 3 trials. 2 trials in systolic heart failure and 1 in preserved ejection fraction. And the trials in systolic heart failure was 1 with ACE inhibitor intolerant patients, the ACE CHARM alternative, and 1 study where we added a candesartan on top of an ACE inhibitor. And I won't go through the whole program. It's later shown that candesartan or ARBs were not better than an ACE inhibitor, but this is the study group, and as you can see, this was some years ago with Dr. Granger, Pfeffer, myself, Youssef, and Dr. McMurray, the leader group in the CHARM program. We had 10 very stimulating years together. I'll just show the CHARM alternative, because that offered an alternative to patients who didn't tolerate an ACE inhibitor, where we could show that adding candesartan had significant effects also in this situation. So at least this program provided an important option for those patients who didn't tolerate an ACE inhibitor. But as I said initially, there is more things happening in the RAAS system, and further downstream is the action of angiotensin II on the adrenal gland, and with the production of aldosterone, which has been known for several years to have cardiovascular impact. And in the new guidelines, this is added as the next step after the ACE or ARB, together with a beta blocker, and as an alternative. And that is based on mainly 2 trials. The first one was the RAAS trial in very symptomatic patients in NYHA class 3 or 4, and where spironolactone or placebo was added, and showed this trial was also stopped, a very clear effect on survival. However, in this trial, this was before the beta blocker era and by the end of the 90s, so there were only 10% of the patients that had a beta blocker on board, so it really didn't tell the added effect of spironolactone on top of a beta blocker as well. But there was a gap. How about the much larger population with systolic heart failure, and that's those in NYHA class 2, which, because they weren't in this trial, was that worthwhile to treat them as well with the addition of a mineraloreceptor antagonist. And we tested that in the emphasis trial, and where we could show that there was a 37% reduction in the composite outcome of cardiovascular death or heart failure hospitalization, and also, and probably the reason why the study was stopped by the DMC, because there was also a 24% reduction in the all-cause mortality. So that made it into these 2 trials, really made it into a third option of adding a third neurohormonal blocker to the other 2. So what is next? Well, looking into this cascade of events, we can see that an important enzyme is neprilysin, and which breaks down both BNP and other vasoactive peptides, as well as angiotensin II. And that has been known for several years, and studies in the early 90s had, with agents targeting neprilysin, didn't, however, translate into clear benefits. So that was not pursued. But then there came up an idea in the 15 to 20 years ago of combining an inhibition on neprilysin with a RAAS inhibitor. And that was tested with an agent called omapatralat. However, that turned out to have increased side effects, angioedema primarily, and that was abandoned. But then a new molecule was produced combining sacubitril, which inhibits neprilysin, with valsartan, and documented angiotensin receptor blocker. And the beauty with this is that if you inhibit neprilysin, you get more angiotensin II, but if you block the effects of this elevated concentration of angiotensin II, you could hopefully add benefits to the neprilysin inhibition. So we were part of a group that designed and did a trial called the Paradigm, and I assume you have all heard about it. It was published now 3 years ago. And the concept here was, with this agent, we were asked to design a study that could show if this new agent was better than what we had, that is, an ACE inhibitor, and the gold standard for ACE inhibitors is enalapril. So we design a study in this way. In order to show added benefits of this, you had to have a head-to-head comparison. We were not going to test this new agent on top of what we had, but it should be instead of. And further, you cannot combine an ACE inhibitor with this new agent because of the sacubitril. So, and also, if we were going to add or show that this was better, we needed to have an ACE inhibitor dose that was documented and accepted by regulatory authorities. And based on the SOLD trial, where the average dose was 16.3 milligram, we needed to select patients that could tolerate at least that dose level. So what we did was to test patients with up to 10 milligram BID of enalapril. And if patients didn't tolerate that dose, they were not eligible for the trial. If they did, they were switched to this new agent, sacubitril valsartan, and titrated up to a target dose of 200 milligrams. And if they tolerated this, they were then randomized to enalapril or the new agent and followed. The study was included 8,400 patients and provided a lot of new interesting findings. And I'll review these briefly with you. The primary outcome was there was a 20% reduction in the composite of cardiovascular death or heart failure hospitalization, as was the two components of this outcome was also reduced by about 20%. And further, all-cause mortality was reduced by 16%. And 16% happens to be the reduction on mortality in the SOLD trial I showed you before. So this seems to be a doubling of the effect of enalapril by using this new agent instead. However, and I haven't shown you this, in the trial, 70% of the patients were in the NYHA class 2, so they were mildly symptomatic, but symptomatic. And I'll put some questions that I've received in the discussion of this trial. Now, is this agent effective across the spectrum of heart failure? Because of what I said, we had the 70% in NYHA class 2. So what we could do, because we had a spectrum in the study, we used a risk score based on a large database and could see that a higher risk score is associated with higher risk. And that can be seen also in the black curve here, where the risk increases with higher risk score, but it also, in the blue line, shows that the treatment effect is similar across the spectrum of heart failure. And this is another way of showing it in quintiles instead of quintiles of risk score, and you can see that this effect seems to be consistent across various risks. Another question, is it effective in patients who already have optimal therapy? And if we look into cardiovascular death based on the presence of an ICD or not, the similar treatment effect. If we look into beta blocker above a target dose of 50% of the target dose, versus no beta blocker, there is similar effect with no interaction between these different levels. So on top of various doses of a beta blocker, similar effect. And this is the background of an MRA where once again you can see that there is a consistent effect on top of background therapy of an MRA. Now, also a question that is of clinical importance. Does this agent work in lower than the dose levels used? Of course, the trial itself cannot answer this because all patients were randomized to the target dose because they had been tested on that. So we cannot give a definite answer, but what we can do is to look into those who didn't tolerate the target dose during the study. They weren't withdrawn, of course, but followed. And this is an analysis. First of all, we can see that patients who have a dose reduction, they are at higher risk, more events, which is what you should expect because they are probably sicker. So, but if we then compare those with the lower dose, or we can see that the effect is maintained regardless of patients maintained on this target dose, or if they have received a lower dose. But once again, they have entered on this top dose and they are not randomized to different dose level. So it seems from the experience from the trial as it works also in lower dose levels if patients do not tolerate this. So what about the important clinical situation? Here is a patient who is stable, is doing well, but still symptomatic on an ACE inhibitor, an MRA, and a beta blocker. What about that? So we looked into that in this analysis. First of all, we could see that 20% of the most stable patients had a primary event. That is, those patients who had not had a prior hospitalization. 17% died during the course of the trial. And in the most stable patients with an event, death occurred prior to a heart failure hospitalization in 50%. That is, they didn't deteriorate first and then, so to say, picked up in the hospital. And 60% of these deaths were sudden. That is, in the clinical situation, it is difficult to predict and when switching. And it's this tells you that it's not in relation to worsening. And if we look into the risk, we know that once there has been a hospitalization for heart failure, that triggers a risk. Those patients are unstable and, of course, needs, if possible, an improved treatment alternative. But if we then compare the treatment effect across various risk levels and including no prior heart failure hospitalization, we can see that the treatment effect is consistent regardless of the timing to a prior event. That is, stable patients are as eligible for this treatment, and the treatment effect is as good as in those deteriorating. Of course, it's important to ask, is it safe to use this? Well, first of all, this agent, sacubitril/valsartan, is more effective than an ACE inhibitor in lowering blood pressure. That we knew. And the difference in the trial was about 3 millimeters. This is not much in a heart failure situation. And this also translated into more patients with symptoms from hypotension in the sacubitril/valsartan group, but very few of these were serious, that is a marked hypotensive reaction. The renal impairment was less progressive in the sacubitril/valsartan group, and there were fewer cases of hyperkalemia and fewer cases of cough, but once again, all patients had been tested on both agents before they entered. The withdrawal rate were similar and actually slightly less in the sacubitril/valsartan group than in the ACE inhibitor group. So it seems to have been well tolerated. And the numbers in angioedema were similar in the two groups. Once again, all patients had been tested with the two agents before randomized into the trial. So now in the guidelines, this treatment, both in the ESC and American guidelines, this has been an option to replace an ACE inhibitor with this new class of drugs. There is only one available, angiotensin receptor neprilysin inhibitor, ARNI. And the question is, as I said, when this should be done, and if you run through this cascade. And that is up to the clinical situation. And this is just a network analysis from Dr. McMurray's group, where they had looked into the treatment effect of single neurohormonal blockers, and by adding them on top of each other. And if we combine three neurohormonal blockers, we can see that we are talking about a reduction in mortality by more than 60%, which is, I think, a major development in the treatment of these very sick patients who still aren't cured but remains at risk. So in conclusion, pharmacological treatment of chronic heart failure has improved markedly over the last 25 to 30 years. The control of neurohormonal activation by a combination of at least 3 neurohormonal blockers is essential. However, morbidity and mortality remains high, and further development is needed in order to improve the outcome in these patients. Thank you for your attention.